So we're going to move into the next part of our agenda for our second keynote speaker. And just before we do that, this is where we start to talk about technology. And you've heard it mentioned in a number of the previous previous presentations that technology is such a key component to the improvements and transformation that are required within the healthcare system. As I said in my opening comments, I believe that technology is probably one of the biggest single drivers for quick improvement within the healthcare system. And it's unfortunate we still have that snicker when we talk about e-health, and I've said this a number of times. We need to move beyond that because e-health and technology are actually going to advance the healthcare system, as I said, much more quickly than probably many other initiatives that we have on the go right now. Now, within the Southwest LHIN, we have several e-health initiatives that will vastly improve access, timeliness, and quality of care. And I'd just like to go briefly through and hit on some of these to give you an idea of some of the work that's been going on within our LHIN. The first one is Spire, and you've heard Spire mentioned a couple of times. Spire is a project which allows the electronic transfer of records between hospitals and family physician offices. When I first came to the LHIN, there was a physician in Byron, Dr. Kathy Folds, and she was giving me a real hard time saying, I'm sick and tired of getting information from hospitals by fax. And up until just recently, and it still happens today, that information is going back and forth between hospital and family physician offices by fax. Who uses faxes anymore? The healthcare system. So Spire is allowing us to move beyond that, where the electronic record is actually transferred from hospital to go into the family physician electronic medical record, and it actually goes right into the system, and it's there for the family physician to use. We've had family physicians, and we have 400 signed up now across the Southwest LHIN, and we're expanding it into Erie St. Clair LHIN. We've had physicians tell us that it's saving them up to 45 minutes to an hour every day in paperwork. So you can imagine in terms of what that means for the family physician, in terms of time available that they could spend with their family, or time available they could spend, additional time they could spend with patients. You've also heard about eShift, one of our quality award winners, which has really changed the way that we can provide care to medically fragile children and palliative care patients. We have many other initiatives underway, and many of these initiatives are larger initiatives that go beyond the Southwest LHIN. So what we've done within the Southwest LHIN, we've actually partnered with the 4 LHINs in Southern Ontario to create a cluster. So the Erie St. Clair LHIN, which is Windsor, Sarnia, Chatham, us, the Hamilton, Niagara, Haldeman, Brant LHIN, and the Waterloo, Wellington LHIN have formed a cluster to look at how we can roll out initiatives across the 4 LHINs so that we're not duplicating things 14 times across the province. This is what the ministry wants, it's what eHealth Ontario wants, and it's what patients and residents want, is to have some consistency across the geography within the province. Another great example we have underway now is a project called Connecting Southwest Ontario. So eHealth Ontario has funded us in the Southwest cluster, those 4 LHINs, to move towards an electronic health record. We've heard that electronic health records have been coming for many years. It's the provincial goal that the electronic health record will be in place by 2015, and we're moving towards that with some foundational pieces like the Spire project, which will help get us there. So there's lots of technology-based initiatives that we have ongoing within the Southwest LHIN. And I think we should be proud of the work that we've been doing. Now with that, I'd like to introduce our second keynote speaker, Dr. Daniel Sands, who is the Director of Healthcare and Medical Informatics, Internet Business Solutions Group at Cisco. Dr. Sands will talk to us about using patient engagement to improve preventative care and health outcomes. And he's going to talk to, and this will come clear when you do your presentation, explain information quality asymmetry versus information symmetry, describe how technology can help enable information symmetry and quality, and list 2 ways in which patient engagement can improve quality outcomes. So with that, I'd like to ask Danny to come to the stage.
Thank you. So, thank you very much. I just came up here to get the remote, but it's a pleasure to be here. What an amazing group gathered, all of you focused on quality. It's so exciting. And I like the name of this conference, the subtitle of this conference, that we're putting patients at the center of care, which is really one of my definitions of what quality care is. And that's why I've entitled my presentation, Whose Quality Is It Anyway? Why Tech-Enabled Patient Enablement Will Be Healthcare's Salvation. So first, let me just say a few words about who the heck I am. I'm this guy from Boston, and I'm a doctor. I'm a primary care doctor, and we have some primary care doctors here, right? I should take, am I okay? Primary care doctor? Who else is a primary care doctor? There, okay, there, over at the periphery there. Yeah, so congratulations. Give a hand to the primary care doctors here. That's good. I'm a primary care doctor. After I did my medical training, I trained in health informatics, in clinical informatics at Harvard and Beth Israel. And I actually worked I worked in health informatics for a long time at the medical center, where I had operational responsibilities for many systems, including the electronic health record, clinical decision support systems, our first clinician portal, and our first patient portal. And I'll be talking a little bit about patient portals as we move on. I left full-time, well, I never was a full-time primary care doctor except when I was in training. I went to industry after I was almost 14 years at the medical center at Beth Israel in Boston. And I left and I went to industry, and I was a chief medical officer at a technology company for a few years. And then I was recruited over to join this company called Cisco. Cisco, right? That's the guys that drive those trucks around and they bring food around to conferences and restaurants. No, it's the technology company. And I didn't understand why they were calling me, because I said, Cisco, but you guys do like switches and routers and stuff and networks, and I do like applications, and I'm trying to change healthcare. And I don't honestly know the difference between a switch and a router. And they said, that's okay, because what we want you to do doesn't involve switches and routers. It involves making a difference in the industry. And that is part of what I do, is I'm really trying to make a difference in the industry throughout the world, but particularly in North America. I still practice a half a day a week, too, which makes my life a little bit complicated, because my full-time job is with Cisco. So I do this healthcare transformation stuff, and we'll talk about that in a minute. But I work with an incredible team of people, and the reason, people ask me all the time, why would a doctor go work for a big technology company like Cisco? And this isn't an advertisement, I just wanted to explain where I'm coming from, because I'm not going to talk about Cisco stuff here. Cisco is all about connections. Cisco was created to connect computers and connect things, right? And so healthcare is the most disconnected industry you can imagine. And that's what I really wanted to fix in healthcare, is I really wanted there to be connections. Well, I said I was going to come back to this healthcare transformation stuff. Sorry, I got to grab this. And so I have a kind of high energy, and I was really excited, and I decided in the beginning that what I wanted to emulate that great Ontario hockey player, Wayne Gretzky. Wayne Gretzky, right? And he's just a year older than I am, I found out. But Wayne Gretzky was amazing, right? And everyone knows what he said. He attributed his greatness to the fact that he didn't skate to where the puck was, he skated to where the puck was going to be. Fantastic. That's what I wanted to do with healthcare. I said, yes, I know what I'm doing. Sorry, I didn't make space. So I know what I'm going to do in healthcare. That's it. I want to do that. The problem is this. The more I dealt with healthcare systems around the world, particularly in this hemisphere, and the more I dealt with healthcare and the way things work, I realized it's the wrong analogy. Healthcare is nothing like hockey, ladies and gentlemen. I've decided that my goal in healthcare is another Canadian sport. It's curling. You see, somebody throws a big stone, right, after a few beers, I understand. And you throw the big stone, and then there are these guys with the brooms who are just trying to move that big stone a little bit. That's me. Just trying to get it to move just a little bit. Because it's hard. We're really well entrenched in healthcare. We've been doing things the same way for so long, both from a business standpoint and from a cultural standpoint. So that's really what I'm interested in. I really want to make big impacts, but I also understand that it's important to make incremental changes. In other words, it's great to have big dreams, and you can bring someone up here and talk about the healthcare system of the future. And I yawn at those things, and the reason is because I want to know how we're going to get from here to there, right? So let's kick this off. I want you to put on your patient hats to start with. Okay, so everybody put on your patient hat. Forget if you're a provider, an administrator, work in a ministry, whatever. Put on your patient. I know the patient hat doesn't really look like this. It probably, I don't know what it looks like. But put on your patient hat for a minute. So I want you to imagine a healthcare system in which patients are respected as partners, in which information is accessible to you whenever and wherever you are, in which you as the patient collaborates around your care plan. That is, the care isn't being foisted upon you and your doctor has it in his head, not sharing it with you. You're part of that. In which care is coordinated and you're not dealing with information all over the place and people not talking to each other and so on. But the coordination needs to involve you and your informal care providers as well. A healthcare system in which non-visit-based communication and care is utilized and valued. You know, it's a fascinating thing. Let me ask you a question. All of you probably have had a blood test, let's say, or a test. It doesn't have to be a blood test within the last year, I'm guessing. So how many of you got your test results without having to go see your doctor? Okay, I got a few hands. It's a big audience. I got 4 hands. How many of you would like to get your test results without talking to your doctor? Okay, put down your hands. So that was almost everybody, by the way. Now, let me ask you this. How many of you have to wait too long before you can go see your doctor? Almost everybody again. So if you were designing a healthcare system, wouldn't you say, well, maybe we don't want to be using up the doctor's visit times. If there's such a wait, there's such a demand, let's not use the doctor visit times for things that don't have to be done in the office. It just doesn't make sense, right? All right. Since we're talking about some of these imagine if you will kind of things, how many of you can communicate with your doctor by phone? We'll start easy. Surprisingly, to me at least, it's a small proportion of the audience. Okay, now I'm going to ask the big question. How many of you can communicate with your doctor through text or email or social media? Obviously, it's a smaller number. There's about 4 or 5 hands up here. Okay, how many of you would like to be able to do that? Okay, this is what we're here to talk about. We got our work cut out for us. Now, I just came from the COACH conference, the eHealth, Canada eHealth conference. Were any of you there? Some of you were, I know. A few of you were there. Glenn was there. So I was on a panel, and the first 2 people were talking about technology. And they were talking about all the technologies and all the data about who's using this technology and blah, 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 blah. And I said, when it was my turn to talk, I said, wait a minute. We got to do some simple blocking and tackling first. We can't handle the system that we have now. We don't have electronic health records everywhere, do we? We don't. Okay? We don't have patients who can access their doctors outside of the office. It is incredible how many things we have to do. The real killer app, killer technology is this. It's the internet. And you know what? It's not that young. It's not that new. It's not that bright and shiny. But it's really important. It underpins everything. Because the web becomes a key enabler to healthcare because patients are now connected to information and to each other, as well as to their doctors and healthcare systems. And that makes a huge difference. I might add, to make it even more interesting, that it's not just the web, but it's the mobility of the web that is even more interesting. How many of you carry a smartphone of some sort? Almost all of you. We're in the land of the BlackBerry. I'm sorry to hold this up, but that's amazing. It is incredible that you can access the web. You can access information from anywhere in your pocket. I mean, it's right there. Doesn't anyone find that amazing? I think it's an incredible thing. We take it for granted, of course. Anyhow, let me move on. I have some data from Pew Internet and the American Life Project. I just want to talk to you for a few minutes about the online health habits of Americans in the U.S. And I do know from other studies that the numbers in the U.S. adults is not too different from at least the southern part of Canada. And so let me give you some numbers. 84% of online adults have gone online to look for health information. 84%. And roughly 85 to 90% of us are online. So this is a large proportion of the population. That proportion is rising over time, and it's quite humbling to know that every day more people search for health information online than see a physician in the US. And more than half of the people act on that information in some way. Now, the reason that's interesting is those of us who are doctors in the audience know that there's a lot of literature showing that patients listen to what we say less than half of the time. Now, it's not quite a fair comparison, but it just is quite humbling. People are paying attention to what's going on here. I should put out a disclaimer for a second. I know we have a lot of, how many nurses are in the audience? I know we have a lot of nurses in the audience. When I say doctor here, I'm using the word advisedly. I will say provider when it applies to both, but we have certain cultural issues in all of healthcare, but doctors we have our own sets of cultural issues. So I'm picking on doctors intentionally. So it's not because I'm leaving out other providers. I just want to make that clear. 34% of online users have read about others' health experiences. 34%. So think about that. People are going online and they're finding about, what was your experience when you took that drug? Or what was your experience with that doctor or health system? Whoa, that changes everything. And I don't know about how much of that is happening here, but in the US, doctors are very afraid of this. Healthcare systems are very afraid because all of a sudden, people are giving their opinions about things. And as you can see, a third of the population is reading it. That changes everything. This is all user-generated stuff. 27% of online adults have tracked their health information online. That's a lot. Admittedly, a little bit of self-selection, right? It's not necessarily the slugs that we're really trying to have an impact on for public health. And then this is an old survey from Pew. 9%, in 2009, 9% of the population that was online used health apps on their smartphones. Now, if you think about it, the iPhone isn't all that old, okay, and the advent of apps. So there's some data to show that this proportion is going up. It's doubling every year. So this is an up and growing class of things we got to think about as well. Okay. The question is, in the words of the crusty New Englander, you can't get there from here. How are we going to get there from here? What are the things we need to actually accomplish a healthcare system transformation? And I've broken it into sort of three things that I think are going to enable this transformation. The first is incentives. Pay people to do the right thing. I don't mean you have to pay doctors for doing email with their patients. I mean, just provide the right incentive. If you pay doctors to do more stuff to more people, guess what they're going to do? They're going to do more stuff to more people, right? It's very simple. That drives up healthcare costs, and it doesn't accomplish greater goals. If you pay hospitals, healthcare systems, doctors, and providers, anybody, if you pay them to provide high-quality care, or you incent them to maintain quality and keep down costs, that's paying them to do the right thing. And the interesting thing about this is this unleashes innovation, right? Because you don't have to micromanage what people do or how they practice or anything. Just give them the general incentives, general guidelines. We want these kind of outcomes to occur, and we want you to keep your costs down. And you know what? People are going to be really innovative. People who use email in their practices, when they're in a capitated system, when they're in a system where they basically get paid a salary, and it doesn't matter really how many people they see or whatever, they tend to use this more, especially if they have incentive to keep costs down, okay, which is very interesting. So I think we can incent people to do the right thing. The second thing is data liquidity. Making information available to patients, to providers, and I love the project you're doing here. You're getting rid of the fax machine, which is great. And I'll one-up you, by the way, since I'm interested in how we communicate in healthcare. Not only is healthcare one of the last industries to use the fax machine, but it is the last industry to use pagers. Because I can tell you, from my experience, that plumbers and electricians gave them up, okay? I am told that drug dealers and even prostitutes don't use them anymore. But in healthcare, we love, I only know that from hearsay, but we love our pagers. Anyhow, back to data liquidity. Data, we need access to the data. Providers need access to the data. We spend a quarter of our time looking for information, and it should be right at our fingertips. And that's as a provider. Now, all of you patients out there who raised your hands, you said what my patient said. How many of you know e-patient Dave? Have heard of him speak or something like that? I know a few of you have. I'm not going to tell the whole story about this. This is one of my patients, and he speaks publicly about this. But he's gone up, and he goes in front of audiences like this, and he says, "Give me my damn data." You all should be saying that. Okay? My friend Kevin Leonard, who some of you know, he says essentially the same thing, right? I want my data so I can take better care of myself. So I think that's the second thing we need, second lever. The third lever is culture. Culture. And we've got to change culture. And culture is so entrenched in healthcare. And of course, it is an industry that's, thousands of years old. And it feels like an industry that's thousands of years old sometimes. But changing the culture, and by the way, it's not just to pick on providers and healthcare organizations. Yes, we need to change. We need to change what we do, but we need to change patient culture as well. Right? We need our patients to change. So many of our patients view healthcare as a spectator sport. And we as physicians are perfectly happy, and I said physicians intentionally, we as physicians are happy for them to feel that way because we feel powerful that way. We're in charge. That's not right, and we'll get back to that. Okay, so how does this play out in the short term? And I'm going to go through these things in more detail. Let me just list them off for you, and we'll move forward. So I broke it into a few areas. And I said short term because, again, I'm not talking about 5 years from now, 10 years from now, because I don't know what the heck's going to happen in that time frame. But I know what's going to happen in the short term. I know the low-hanging fruit. I know things that are happening now in Canada, in the US, other places in the world. So they're not a reach. So, didn't mean to go forward. Okay. So the content piece of it, I'll talk about this. Information symmetry, I'll talk about. General versus personal information. What I mean by that is that, okay, let's say you have diabetes. And I direct you, you should have access to information about diabetes. That's fine. But you need to have access to your information about your diabetes, your record information. Self-directed testing is a huge thing, that's a huge trend we got to understand as well. Then there's collaboration. What I've called new communication channels, and you're going to laugh when I tell you what I mean by that. Patient portals and shared care plans. Community, peer support online. Really, really important, as you heard about in the previous slides. Quantified data sharing. That is, patients not just sharing ideas and soft affective information, but sharing what's actually going on with their health in a quantitative way or semi-quantitative way. Patient-initiated research. Wow. Just turns the whole world upside down, doesn't it? When we are sitting at our desks in our healthcare institutions, we're very provider-centric, and we got to think differently. And then there's care, of course. It's remote monitoring and self-monitoring, shared records, and then when is face-to-face care really needed? So let me delve into these a little bit, and we'll go fairly quickly because I want to make sure there's time for discussion. On the content side, I quoted Wayne Gretzky, now we're going to go to Francis Bacon. I don't know what that means. Knowledge is power. You've all heard this. But sometimes we don't think about really what that means and what it means in healthcare. What does it mean? Well, here's the thing. For thousands of years, we in healthcare, particularly the doctors, we are proud of the fact that we are so learned. And we are. We spend so much darn time in school and training. And yeah, we know a lot. We don't know everything. We think we do. So here's the thing. We lord this over our patients. We lord it over our patients. And it's a problem. So what we have is a situation called information asymmetry. And this is a term from warfare and economics. But the idea is that the physician knows everything, and the patient knows nothing. Now, many physicians are comfortable with this because this is the way we grew up. This is the way we were educated. What was Mrs. Smith's potassium today? Oh, it was 4.2. And what was it yesterday? Oh, it was whatever it was. And what was it before she came in? We're asked questions all the time. What are the 50 causes of syncope? And as we're training, we have to regurgitate this information. And we never say, I don't know. That's totally beaten out of us. So we are proud of the fact that we know a lot. We are comfortable in the role as the oracle. I think it's a burden. And I say it's a burden because we can't know everything. There are 1 million articles indexed in Medline, that is the world's medical literature, 1 million articles each year indexed in Medline, right? If I keep up with 2 journals, and I read 2 journals religiously every time they come out, by the end of the year, I'm already several centuries behind in my reading. I can't know everything. Now, I'm a generalist, okay? So, see, specialists like to know everything, and what they do is they become more and more specialized. So they learn they learn more and more about less and less. And until pretty soon, they know everything about nothing. But I and the other primary care physicians, we're all generalists, okay? We have a different attitude, is that we want to know, we know less and less about more and more, until pretty soon we know nothing about everything. So my point is that since none of us really can know everything, and we really don't, if we're acting like we do, that's stressful. That's living a lie, living a double life. You have this deep, dark secret you're not sharing with anybody. I'm really a fraud. I don't know everything. But we're not comfortable doing that, so we hide. So I think this is a burden. And I think we have to understand that we can get beyond this. We can move to an era of information symmetry, where the physician and the patient are partners. And we appreciate the fact that our patients have something to contribute, can learn about their own health. You can go out and read things, do your homework, and you have access to the same information that I do. Not necessarily the experience, perhaps, and the wisdom, but I'm an expert in medicine, I guess. You're an expert in you. You know you better than I ever will, and I've got to respect that. And I think that rather than feeling threatened by this, physicians need to feel liberated. Thank God I don't have to live a lie anymore. I don't have to pretend I know everything. And if we do that, we in healthcare can go back to being healers. I mean that in a holistic sense. We spend so much time focused on just knowing that information and getting that information right away. It's not right. So I think we can relax, and that's good. I like to teach doctors this. It's the power of I don't know. So this is part of the therapy session that we go through with physicians as I teach them. It's like, you got to get to the point where a patient asks you a question, and instead of saying, oh, let me go check, and you go look it up or something, or go ask a colleague, you actually stay there with the patient. Okay, listen, it's really hard. And you look them in the eyes, and you say, I honestly don't know. Now, if you do that, you start to do that with people, and you start getting a little bit comfortable with that. That was the first step of your therapy. And you can teach this to your physicians, too, by the way. The next step, now this is really hard, okay? The next step is that you say, I don't know. Then you say, let's look it up together. Oh my God, the first time your physician says that to you, you'll like, what? You'll faint. It's really, but it's really amazing. It's transformational in the relationship. Let me tell you something. All of a sudden, I'm human, and we can look it up together, and that is huge. Okay, lots of information online. This is one of the very popular sites, WebMD. I'm sure you've all seen that. Patients are looking up information, and you know what? It's good information. How many of you have gone online to look for health information for yourself or a loved one? Almost everybody, right? How many of you think it's bad information online? Not that there is no bad, let me say that differently. How many think that information online is a bad thing, as opposed to, I know that there is some information online that is bad. So how many of you think it's bad, that all this information online is bad? Anybody? There is bad information online. But studies have shown, actually, that patients are pretty good at telling the difference between good and bad. Okay? And there's a lot of good information. It may not be very deep. That's another issue. But patients can go in, and this is kind of a neat thing, they can do this symptom checker. I'm not saying it's great or it's perfect. It's interesting. It leads to interesting discussions and conversations. So here's my recommendation to clinicians as you're dealing with patients. You start by asking the question of your patients, of every patient. Because the studies show that, yes, there's a digital divide, and I'm sure that there are a lot of Inuit, maybe, who don't have access to the internet and looking up things online. At the same time, it's not who you expect. That is, the people who are online are not just the young, wealthy, educated people. Okay? They're the elderly, which is the fastest growing population online. They're immigrants who may not speak French or English as their first language. They can be anything. You're just not going to expect it. So you have to ask every patient who comes into your office, have you ever gone online to look for health information? And they're going to be surprised you asked them. But it's a good thing, and it's a good thing because now I know where you're getting your information. That's good. So I'm going to ask a follow-up question. I'm going to say, what are some websites that you like? You may say, I just Google, and that's fine, or I go to WebMD. I'm going to write that down, by the way, in your record. Just like I write down whether you have some strong religious convictions or you may be a Christian Scientist or something or a Jehovah's Witness, I'm going to also write down whether you use complementary or alternative medicines. That's all part of your record. This needs to be part of your record as well. I need to know that. But there's something else here, which is this. By asking the question, by opening the door with you, I'm giving you tacit approval. So you don't have to be afraid to say, Dr. Sands, I read something on the internet about whatever, because you're going to be afraid that I'm going to laugh you out of the office. Surveys have shown that patients don't tell their doctors what they're doing online because they're afraid their doctors are going to laugh at them. They're going to poo-poo it. But that's the wrong approach. That's why you have to be proactive and you ask everybody, do you go online and look for health information? Ask them every year when they come in for their checkup. Okay? Record it in the records, and that's giving you the tacit approval, and that's good. And that's going to lead to these honest disclosures, and that's what we want. We want a trusting relationship. And that's what we too often don't have today. Okay, let's talk about collaboration for a few minutes. What is collaboration? Well, it's co-labor. It's working together, right? So we collaborate to share and co-create knowledge, to learn, to negotiate, build consensus. And I would say to you that in healthcare, we have two big reasons for collaboration. One of them is to coordinate care, to do the kind of collaboration we need to do to take effective care, to look like one healthcare system instead of many different independent entities. Okay? So it's the collaboration on the part of the providers of care. But the other kind of collaboration we often forget about. It's the collaboration between a patient and a provider. That's collaboration too. Every time I'm providing care for you, we should be thinking about this as collaboration. And that changes the whole mindset, working together. So this is one of the advanced technologies I want to talk to you about. It's called email. Maybe you've heard of it. We haven't in healthcare very much. In 1998, I co-authored the very first guidelines about the use of email in patient care. This was some of you aren't old enough to remember this, but the World Wide Web started in roughly 1995, let's say. And that's when, even though the internet existed beforehand, that's when everybody all of a sudden had access to the internet, mostly. So there was this, all of a sudden, everybody had an email address by say, about 1998, maybe. Give it a few years. So I wrote these guidelines, I co-authored these guidelines, and I thought, okay, I already knew from surveys that patients were dying to do this with their physicians. But I was trying to convince the physicians that it was okay to do it with patients. And you know what? Didn't work. Didn't work. It was a good paper, I thought. But we got a lot of interest from patient groups and from the media, but it didn't interest physicians in the least. We'll talk about some of their objections a little bit later. But now there's been a serious uptick in the use of email in patient care. It's still not the majority, at least in the US. And I won't go into what email is. Frequently this is not email per se. It's not like what you're doing in Outlook, but it's something more like the way you send mail to your bank, right? RBC, you're sending them a secure email. That's what I'm talking about most of the time. But even plain email is good. And it adds so much. Because if the only time, and it's not just email, but if the only time you're communicating with your healthcare team is when you're sick or you're in for a regular visit or you're going to get your test results, that's not enough. You need to augment that through other contacts, little contacts over time that don't require a large commitment on the part of the providers. And email is particularly nice because it's asynchronous. So I don't have to do this in real time. Our phone calls, when you can reach your physician, are very rushed. Email is much better, and many patients feel rushed. We feel rushed, our patients feel rushed. Phone isn't working for anybody in many cases. But electronic communication, it's asynchronous, and that's its huge benefit. In 2004, I wrote an opinion piece in the New England Journal that reviewed some of this, the reference at the bottom there if you need it. All right. I said I was going to talk about patient portals. I'm not going to go into detail about a patient portal. A patient portal is simply a website into which patients and providers can log in. And this is a website that I helped build called Patient Site. It's been up for 12 years, if you can believe that, a long time. You can go to this website and try the demo. Let me just tell you what the elements of a patient portal are, because I believe that a patient portal is a very important tool for this types of collaboration and transformation that we're talking about. First of all, it's this secure messaging that I mentioned to you, where messages that are clinical might go to me or maybe to a triage nurse. And if they're not, they're going to go to the prescription team or the appointment team or whoever needs to take care of these things. I don't have to deal with these administrative messages. And then there is a whole bunch of services that we provide to patients, online services. It's just amazing to me. I'm not going to ask for a show of hands. I know that most of you don't make your airplane reservations through a travel agent anymore, right? We rarely go to travel agents. We do them online. Why is it that we tolerate calling up our doctor's offices to try to get an appointment? It's just an appointment. We're not doing a multi-stop tour across Canada. This is easy. So it just blows my mind. So what we do is we provide patients tools. They can get their prescription renewals, they can get appointment requests, get referrals to specialists, and so on. And then we have a lot of education that we provide through this as well. I can prescribe information to my patients. But the most interesting thing, I think, is that patients can see their records online. They see their records. How cool is that? You have access to your information. Done. And you want to ask a question about it? We're here. We got a team of people to help you. And that's really cool. That's transformational. It's really transformational. All right. One of my patients, a consultant with hypertension, hyperlipidemia, after he started using this website, he said, this is a direct quote, "This is too cool. It's almost silly that things can be this easy. I am having a very good patient/customer experience so far." But, you know, some of the conversations today, Dr. Mayer's talk earlier today talked about some of the more affective components of this. How does it feel? And this note from a minister who's actually quite ill, he said this: "I have a lot of medical issues. This email system has left me feeling comfortable and in good hands. Otherwise, I would feel as cold, depleted, and alone as the lifeless tree in my front yard in the deepest of winter." I mean, wow. A little wordy, I understand. But the point is this really has an effect on him that's huge. I have other comments from patients, of course, talking about this. This makes a difference in their lives. And you know what? If it's not making a difference in their life, they may have a loved one who's doing it for them. And this is big. This is big. What about community? ACOR. Anyone here of ACOR? ACOR.org? Okay. Does anyone here know anybody or personally have an experience with cancer? Almost everybody. Then you should know about ACOR. It's a free website that started many years ago. It's, as I said, ACOR.org. It's a website through which you can connect to other patients with your cancer. And you can read information, or you can just lurk on these discussion groups, or you can share information, get information from them, ask questions. It's phenomenal. Since this website has started, these discussion groups have started, and there are 250 different cancers represented on this site. Since they've helped 500,000 people with cancer. It's astounding. So these support communities, you got to remember about them. I think they're really important. One of my patients with metastatic renal cell carcinoma said, "My doctor prescribed ACOR. I prescribed it to him, and it saved my life." That's powerful. Non-commercial or anything. It's free. And then there's adding in data. How many of you have heard of patients like me? It's funny, in the US, they're in the news, they've been in the news many times. Patients Like Me is a patient support community for certain serious chronic illnesses. They started with ALS, Lou Gehrig's disease, and they've moved into many different areas now. But through this website, patients not only connect with each other in the way a support community works, but they're actually able to share data about one another. You know, let's all try taking this medication and see if it works this way, for example. They're doing studies that have been published in the literature. It's really, really cool. So look it up. What about care? Do we need most of our face-to-face visits? That's what I want to ask you. Ask yourself, how many of the last 5 visits that you went to really needed you to take a half a day off work and go see your doctor? Was there really value? If you're at the Ministry of Health, are you getting value for all these visits? What is the value? And isn't there just as much or more value in doing things another way? Shouldn't we be keeping the face-to-face visits for patients who are sick? Wouldn't that make a lot of sense, right? So there are lots of different ways we can collaborate with patients to take care of them. Everything from the telephone and electronic messaging, text messaging, to remote monitoring, telemedicine, advanced telemedicine, and then, of course, the office visit. Each of these is appropriate in certain situations. You know, if you contacted me and said you were having crushing substernal chest pain when you walked up the stairs, I don't want you sending me an email. I want you in the emerge right away, right? But my point is that there are lots of things that aren't that. And we spend a lot of time and money in our healthcare systems taking care of people that way. In the office, it's the most expensive encounter you can imagine. The real estate's expensive, the opportunity cost expensive, your time as a patient is valuable, and my time is valuable because I could be doing other things. We have to think more broadly about how we deliver healthcare and think about these non-visit, non-face-to-face channels of communication. Just need to understand how they can be used. What about care plans? What about getting patients involved? So it's an interesting thing, and you have to tell me if this is true in Canada. So how many of you have a pet, a dog, cat, something like that, a hairy pet? Okay, a lot of you do. And how many of you get a note, a postcard, or a letter from your veterinarian when your pet's due for preventive care, right? Okay, a lot of them, right? You due for a shot, whatever. How many of you get that when you're due for your colonoscopy, or your mammogram, or your pap smear? Why? Why do we? Some of you do, and I'm glad. Very good. I didn't miss the fact there's some hands up. Why is that? Why do we like our pets so much more than we like people? I puzzled over this. But some people have been looking at this, and they say, well, what if we send reminders to patients as well as to doctors? That's another funny thing. We send reminders to doctors, but usually we send the reminders to the doctors, and the patient's not here. So what am I going to do with that? If I'm sitting in front of the patient, good, I can take care of that. But if you're sending me a reminder and I'm doing 27 other things and you're not one of them, sorry. So we got to be involving you. Why cut out the middleman, right? You're due for a mammogram? We'll send you the note, as well as me and the rest of the healthcare team. That's the way we should be doing things. And they're doing that. This is at Kaiser in the US, and they're sending notes to patients to remind them about their preventive health. It's great. Oh, I didn't mean to do that. There we go. Eric Poon, there haven't been many studies of this that I can find. Eric Poon did a study that was published in MedInfo in 2007 where he sort of looked at the impact of this, of sending reminders to patients, and found that it was definitely worthwhile. But then he changed jobs, and I don't think he continued that study, unfortunately. And then there's monitoring. So if I'm going to take care of you, let's make it real simple, okay? I'm not going to ask for hands because this would be a violation of privacy. But I'm guessing, looking around here, let's say 40% of you have high blood pressure. I don't know if that's right, but I just made it up. 40% of you have high blood pressure. Now, I know that when you go to your doctor's office, okay, your doctor, renews your prescription, whatever. The nurse checks your blood pressure. The doctor may not even be touching you, or he might ritually put a stethoscope on your chest. But it's a ritual. It's a ritual, right? Am I right? So much of the time it's a ritual. Now, I'm not saying that you could be a patient who has congestive heart failure. We have to watch your fluids very carefully, yada, yada, yada. But a lot of the people that we have in the office are people who just have high blood pressure. It's very uncomplicated. I need to be seeing you maybe once a year. But your doctors are asking you to come back in 3 months. Your blood pressure is normal, by the way. Controlled. 3 months. Or they're asking you to come back in 6 months. But why? You're an adult. Can't you check your blood pressure at home? Beyond that, you can actually not only record your blood pressure at home, but if we really wanted to, you can capture it. There are all these ways you can monitor yourself. Glucometers paved the way for this. So many of you, of the 10% of you who have diabetes, maybe 15%, many of you have glucometers that actually connect to computers. Or they at least give you a little printout, and you can actually tell what your means are and your max and your min, and all that's great. But now they can connect to your smartphones, and you can graph these things. You can give them to your doctor or your nurse if they want to look at them. That's a whole other issue. If you have an organization that really is interested in your health, as opposed to most of our healthcare system, which is a sick care system, as you know, right? If they're really interested in keeping you healthy, well, there might be a person whose job it is to review this information that's transmitted from the patient's homes. And they can let you know what, your blood pressure's been trending upwards. Please make an appointment, come in. That would make a lot of sense, right? A lot of interesting things that we can do with these technologies. So these are the short-term big wins that I've been talking about, that I've just spent time talking about. So let me talk about a few more things here. The introduction of these new technologies and Health 2.0, which is user-generated content, shifts the balance of power between patients and physicians, and I would actually add, and patients and the healthcare system. There is a balance of power here, and this is changing everything, whether we like it or not. Some of us providers squirm because it's changing things. These reviews that you're writing about me online, I can't control that. You're looking up information on your own about your own health? That makes me nervous. But it doesn't matter. It's happening. And we got to understand that, right? What we need to understand is that patients and physicians each have expertise. And patients can and must help in their health care. One of my mentors, Warner Slack, wrote that it can be argued that the largest and yet most neglected healthcare resource worldwide is the patient. Is the patient. We fail to engage the patient in care properly. We fail to treat them as equals, as people who are sapient individuals who can take responsibility. Tom Ferguson, who was another one of my mentors, the late Tom Ferguson, he was a physician. Anyone know the name Tom Ferguson? Does that ring a bell? Pioneer of consumer health informatics. He was sort of a child of the 60s, went to Yale Medical School, never practiced, and instead he sort of became an observer of what we do in healthcare. And he wrote about that a lot. And he made this observation, which I think is even though it was back in 1995, it's still so prescient. He said, whenever we healthcare professionals, when we talk about healthcare, we talk about primary care, secondary care, and tertiary care. And that's it. End of story. And it's ironic because that is just a piece of what healthcare is. Even more ironic, that's the most expensive kind of healthcare there is. As he observed patients and clinicians and so on, he realized there's this whole other part of healthcare that's called self-care that's just off the map. He called this model industrial age medicine. And again, it's where we're encouraging the expensive forms of healthcare and we're discouraging inexpensive forms of healthcare. And I'll tell you, back in 1995 when he wrote this, nobody was talking about the cost of healthcare. Now we are. He said, let's turn it upside down. Let's encourage individual self-care, friends and families, self-help networks, and then eventually, sometimes, get to professionals as facilitators, professionals as partners, and professionals as authorities. That is what we should do because that's more cost-effective, number one. It's better for patients, and he called that information age healthcare. So what about those physicians that I referred to earlier? Why are we having trouble? And I'm not saying the physicians here are part of that problem, so don't go attack them afterwards. I'm sure they're enlightened, which is why they're here, okay? But we, culturally, as physicians, we're having a problem with it. Physicians are concerned about a number of things that I'll just touch on briefly. They say they're worried, this is surveys, they say they're worried about privacy, they're worried about liability, which is, I understand, less of an issue in Canada than it is in the US. They're worried about how much time it takes to practice in this new way. They're worried about money, time and money being interchangeable, of course. They think that many of these things are helping my patients, but they're not helping my practice. They're not helping me. What's in it for me? And they don't know how to get started with these things. So these are the things that physicians are worried about, some of the things at least. But here's the thing, and I keep pushing the wrong button here. This is a great quote from an article that was in the Mayo Clinic Proceedings. Physicians are reluctant to encourage patient participation because either they refuse to delegate power or control, or they are afraid to lose their identity. Limiting the depth and amount of information given to the patient reduces his or her autonomy and is associated with less participation. All about this information. My message is the cow is out of the barn. We have to get used to it. Okay, we've got to understand this is what's happening, and we as healthcare systems need to understand this. Okay? Technology is coming, it's here, it's an enabler. Your patients are using technology even if you aren't in your offices and healthcare systems. It's fascinating. Now, maybe there's some encouraging news here. I said we let patients see their records through Patient Site. I lied a little bit because we don't let patients see their notes. And those of you who have looked at medical records at all know that there's a lot of information hidden in those doctors' notes, even if you can't read them sometimes, most of the time. So what's in that note? So we're part of a study called Open Notes, where we and 2 other healthcare systems are letting patients see their primary care notes online. And they're trying to understand the impact of that. So I'm not going to bother you with all this. Let me drill down to the point here. Overall, 69 to 81% of participating PCPs across the 3 sites and 92 to 97% of patients thought that open visit notes were a good idea. So let me give you the good and the bad here. The good is that, wow, that's a majority of physicians in this study. 70 to 80% roughly say this is good. It's good to let patients see their notes. They have their concerns. It's not always a good thing. They have their concerns, but that's good. But the thing is, if you look at the patient numbers, it's well over 90%. Patients want this. And we, as a healthcare system, need to understand that and figure out how to deal with that. So there's a changing nature of our relationship. We're moving from a world of information asymmetry to a world of information symmetry. We're moving from patients being passive receptacles that we sometimes fill with little tidbits of knowledge to a world in which patients are active partners in their healthcare. Instead of paternalism, this enables autonomy. And autonomy is really, really key here. It's participation. And rather than just being a patient-physician relationship, it's a consumer-provider relationship as well, and we need to understand which is which. All right. 2.5 years ago, I co-founded an organization called the Society for Participatory Medicine. I'm the president of this organization. And if you're interested, check out the website, become a member. It's only $30 unless you're an institution. And we have a journal. We really want to change the culture of healthcare. It's a movement in which network patients shift from being mere passengers to responsible drivers of their health, and in which providers encourage and value patients as full partners. And the way we're trying to accomplish this, a lot of this is cultural, is we're trying to establish, we're trying to make a difference through our blog and social media. We have a journal to help establish the evidence base. We're influencing public policy. And we're actually doing a lot of programs to increase awareness. Like, if you're a patient, you can nominate your physician to say, my physician is a participatory provider. And your doctor gets to tout that on his website. And your doctor, furthermore, not only gets to tout it on his or her website, but when patients do a physician search through all these different companies that do physician searches, they can search on patients not just who speak their language or take their health plan or whatever, but on physicians who are participatory. It's really cool. So we're doing a lot of interesting things like that. This is a quality conference, and I'm going to highlight just a few things quickly because I want to leave time here. A lot of things that probably, not all of these are yet supported by evidence, but looking that way. A lot of factors that contribute to quality if you engage patients. One of them is letting patients see their records. Provides a second set of eyes that is so important. We miss things all the time in healthcare. We make mistakes. I got to look at all these x-ray results and all these test results. I'm going to miss things as I'm scanning through them. But you are a patient and you have one set of these to look at. So you have the ultimate incentive to really look over these things carefully, and you may draw things to my attention that I may miss. Improved communication in both directions is a boon. I won't even go into that. Many different benefits there. Patients doing research can find their own research, not only in clinical trials, but doing research. So you have a condition. I've diagnosed you with having such and such a condition, and I know something about that condition, but you, again, have the ultimate incentive. It's your skin in the game. So you're going to go off and do as much literature searching as you can, and you have the access to the same things that I do in terms of information. That's great, because you may, again, see things I don't know. I have a patient that he's not a patient, actually, a friend I play soccer with. He's older. He said to me last Sunday when we played, he said, Danny, I feel like I got a new set of legs. He's like 70, believe it or not. A new set of legs. And I said, well, what do you mean? He said, well, you're not going to like it. And I said, what do you mean, Bob? He said, well, my doctor had me on this drug for my cholesterol, a statin, and I was having this pain. And my doctor said, didn't really pay attention to me is kind of what he said. And so I went online, and I found out there are all these patient communities where all these people are having terrible muscle pain just like mine. It felt just like mine. And he said, I finally said, I don't care what my doctor says. I'm going to stop the statin and see what happens. And I'm not saying statins are always bad. They're very good. I have a lot of patients on statins. But he got better, despite what his doctor was listening to or not listening to. Patient participation in note creation is an interesting benefit of this. So I actually do almost all my notes now with the patient. Forget about the fact they're going to read them later anyhow, because now they have access to them. But it makes a huge difference, because there's so many errors that you're going to find when you're looking in your notes. But if I'm doing it with you there, I can actually get your history, talk to you, and we're going over it at the same time. It's accurate that way. It's better. You're going to understand it. And as we're doing the note, by the way, you're going to buy into the care plan. Because at the end of the note, I say, this is the plan for these problems. And you're going to be there while I'm doing it. You agree to do this, I agree to do this. It's great. All right. So let me conclude. Connected technologies enable health system transformation and patient engagement. We can't do it just with the technologies. They lower barriers, but they don't do it alone. To improve quality, we really need to rethink care delivery through the patient's eyes. If we change incentives for providing health care, we change policies around data liquidity, and we change the culture, patient-centric innovation will follow. And although it may be challenging to learn this new dance, this new culture, ultimately it will improve outcomes and both patient and provider satisfaction. Thank you very much. This is my patient, Dave, by the way. Thanks. Questions or comments or disagreements? Arguments? Nobody has any questions? Really? It's easy to leave here going to the microphone. What do you think?
Here we go.
Thanks, Danny. Really enjoyed that.
Thank you.
I'm Gail Sadler. I'm the District Executive Director for Victorian Order of Nurses here in London, Middlesex, and Elgin County. That is not a commercial. Can you take us 8 to 10 years ahead? I've worked for a software company and for technology companies, and really want to start to think these things will happen quickly and rapidly in the next 2 to 3 to 5 years. But what should we be watching for and thinking about and preparing for 10 years from now in the advancements in technology for care, especially in the community?
Wow, that's a tough one. It's a great question. I mean, I started out by saying I don't like to forecast things 10 years ahead, because in healthcare it's hard to predict, because I know that it's very hard to see significant transformations coming, because I remember working in this field in 1993, and then something happened in the next 2 years that just changed everything, which was the web, and nobody saw it coming, not even Microsoft, right? So I think that the things that you want to be thinking of, I think the things you probably want to be thinking more about is how you pay for healthcare. I think that's a key thing. You're thinking 10 years out now. I can't get my arms around 10 years out. I think that patient engagement in their health through technologies that allow them to monitor themselves, that allow them to send their own tests, I think those are going to be things that are going to be increasingly important. I think 10 years out, though, I think we will be seeing more personalized medicine. And that's something that we're not seeing a lot of now, because frankly, most of the genomic stuff outside of cancer isn't really amounting to any useful information. It's sort of what one of my pathologist friends calls recreational genomics. And it's interesting, and you can run your genomes and stuff, but it's not really impacting healthcare in a big way outside of oncology. But that's going to be a huge impact. In 10 years, we're going to have information systems that are able to store your genome and be able to understand what what the SNPs you have and what the genomic information you have that's going to alter therapy. I think that's a big thing we've got to plan for. And right now, I realize you're just doing the electronic health records, but you multiply that by many times in terms of your storage needs, your processing needs. And that's why I think that from the technology standpoint, you're going to need to do things in the cloud. You're going to need to change the way you think about the data center and things like that. But I think that, so I think that's one trend that I think is important to think about. And I think this home monitoring, this having patients monitor themselves is going to be really huge. And I think it's going to be commonplace in 10 years. And we're not going to be so focused on this visit-based care because it just doesn't make sense. Other questions? Yes?
I'm from St. Joseph's Healthcare in London. Part of a group locally of researchers looking at many of these ideas for across the mental health care system, personal health records, self-monitoring, et cetera. Are you familiar with similar projects in the U.S. or anywhere else?
Did you say the mental health system?
Yes.
No, I don't think I know about any projects where they're focusing on this specifically in mental health. I know that, one of the interesting things, though, is that in the institution where I see patients still, in Beth Israel Deaconess, when we first rolled out the electronic medical record in around 1990, we started in primary care, but we immediately went to the mental health practices next, which is a little counterintuitive because we had all the different specialties we could have done. But the thing is that the model of healthcare we practice there, we work side by side with mental health providers. And so, and actually, if you look at even if you don't have that kind of practice situation, in primary care, we deal with a lot of mental pathology, right? Because most of them don't get to mental health providers because we're taking care of them. And eventually, maybe they get to you. So there's this notion that you can actually tease apart the two records. If you move to a future state where you have all this information, that you're going to have to sort of segment the mental health records. And I would just tell you that our experience is you can't do it. Because the primary care physician's notes are going to have a lot of that information. The primary care nurse's notes as well. It has a lot of mental health information. And moreover, it's unsafe. Because do you want us to suppress the patient's psychiatric medications? So if I'm an emerged doc, let's say, and I'm prescribing something, should I not know what you're taking? So, it just doesn't make sense. So when we do patient site, for example, we don't segment anything.
Yeah. So there's a lot of sharing of information between the hospital, the primary care physicians, and professionals in the mental health care system. But these are people receiving the care being able to access their own personal health record, to be able to self-monitor whatever they need to self-monitor. There's a lot of mixing of things like blood pressure and mood monitors, et cetera, et cetera. So it's trying to put it all together, but from the person's point of view rather than the provider's point of view.
Let me just give you two other data points that I think are interesting. One is that it turns out when I looked at the subject of letting patients see their medical records and be involved in their care that way, it turns out there's a pretty big literature in the mental health field, believe it or not, of letting people look at their medical records. So I found that really interesting. The other interesting trend is that if you look at all these, there are allegedly 13,000 health apps that you can get for your iPhone today. And a whole bunch of them have to do with mental health. Everything from sleeping to depression scores to medication monitoring. And I think that's a really interesting trend as well. One might argue it's only for the obsessive compulsive patients, but you get the idea. So I don't know, it's an interesting field. Yeah. Any other questions, comments? Okay, well, again, thank you very much. It's been fun being with you. Thanks very much.
Great presentation. So I think we'll all agree that was a great presentation, high energy, informative, and certainly puts us in a different frame of mind when we're going to visit our physician next time we go. So thanks very much, Dr. Sands.